Hi, my name is Dr. Jerome Thompson. I'm a pediatric otolaryngologist. I was born here, raised here, and then went to school at UCLA and then moved back here. I was at LA Children's first before I came here. I specialize in difficult pediatric airways, and we've written textbooks about this. This story begins with Cooper Kilborn when he's 16 weeks after conception, when he was involved in a serious car accident. So serious that the mother had to have her potentially injured baby ultrasound to make sure that there were no injuries. At that ultrasound, they discovered some interesting abnormalities where they couldn't verify that there was an airway. The child later made it down here to Memphis, where we have a high-risk maternal fetal team at the Med, and we're known for managing difficult newborn airways. The high-risk maternal fetal team is Dr. Mari, right there, and Dr. Meyer. And between these two gentlemen, they gave me the opportunity to see over 2,000 images of Cooper that allowed me to have an idea of what I was going to be dealing with. It became very apparent that there was no recognizable larynx. And we knew that we were going to have to do an exit procedure. An exit procedure is where you take the child and the mother to the operating room and do a cesarean section. But instead of cutting the cord, you leave the child attached to the cord so the child can get the mother's oxygenation from her lungs through the umbilical cord to the baby. We delivered Cooper onto the mother's abdomen and then down toward her legs, but keeping his torso, his abdomen and lower body still inside the womb to keep him warm. We then did an emergency tracheostomy with Dr. Jen McLevy, who is not quite here yet, but she'll come in and will be available to answer your questions later. Dr. McLevy and I did an emergency tracheostomy on Cooper. We ran into some interesting issues, which has always been the characterization of Cooper's course. He's always been able to throw a new curve at us. But after he got out of his initial trauma of the surgery, we had to deal with a prolonged hypoplastic lung syndrome of underdeveloped lungs. And Dr. Schumacher was running the pulmonary care then in the ventilators. Even now, he's still on a home ventilator at night because his lungs are still not quite mature enough to allow him to be completely off a ventilator when he sleeps. The next phase took 2 years. We waited 2 years before we touched him because in our field, you don't bother trying to reconstruct an airway before 24 months because statistically you're doomed to failure. We did research literature and couldn't find anybody who had successfully done a laryngotracheal reconstruction to guide us for a congenital airway lesion. These are called chaos syndrome, congenital high airway obstruction. They're usually just a cyst or just a malformed vocal cord or something like that. The word agenesis means complete, but in the literature, a lot of people call partials agenesis. But Cooper was a complete agenesis. And in the magazine that we have, we had an artist draw an image of what we saw in the operating room. When we took Cooper to the operating room, we identified the normal trachea, and then we tried to identify something that looked like vocal cords. We saw some muscles moving, but we couldn't see a larynx. We opened up the larynx and found a column of solid cartilage with a little round marble of undifferentiated muscle in it, so there was no anatomical larynx. We reconstructed that with 2 rib grafts. Usually you only use 1, but we used 2 to reconstruct one on the back and one in the front. Dr. Ying Weatherall here obtained those rib grafts, which is unusual to obtain 2 at a time, and that took a while. Next, we sculpt those rib graft fragments into structures that would fit into the notches we've carved into this solid cylinder of cartilage. We cored out the inside of the cartilage, trying to make a lumen. And then we put a Teflon stent inside the lumen. And that was to hold everything apart. And then we closed it and hoped for the best. we waited 6 weeks. And then after that 6 weeks, we took him back to the operating room and crossed our fingers and pulled the stent out. And there's a photograph of me looking like an idiot when I saw that the lumen was wide open. Since that time, we've been kind of haunted by granulation tissue from the sutures, but the sutures are critical to hold it together. So those will eventually dissolve and go away, and this issue will not be a problem. This whole thing wouldn't have been possible without certain people. Dr. Jen McLevy assisting me on the surgery, and and Angie Smith, my scrub tech. Angie was with me at the delivery and been with me with every one of his cases. And she was extremely important in that, as well as the anesthesiologist, Dr. Adam West, who isn't here, but the CRNA has also been present each one of those 17 separate operations. Erica Grissom is her name, and all of them need to be recognized. But it's really important that you understand this was a team effort. Without the team in the OR, without the team in pulmonology, without the team in neonatology, without the team in the OR, we wouldn't have been able to pull this off. And Bonheur has given us the opportunity to build an exceptional, difficult airway team here. And we've done many exits, and we've delivered those children here. And this is going to be another significant milestone for us.